Okay, well, thank you everyone for joining us today. We're here to discuss protecting data and AI in healthcare together with Hub Security's very own David Hochhauser. And we're also joined by a number of AI and healthcare security experts on our panel, including Christopher Frenz, Carolyn Crandall, Jack Lewin, Cody Baumgartner, and Ramzi Nouali. We'll start our webinar today with a brief introduction from David on today's discussion topics, and then our panelists will each get a chance to briefly introduce themselves. Afterwards, we'll get a bit of a deeper discussion on everything related to healthcare and AI, security, alongside understanding more in depth its ongoing threats and solutions. As usual, we'll leave about 30 minutes at the end of our discussion for a short Q&A. So if you have any questions throughout, feel free to drop them below in the Q&A section, and we will get to them later on. Now, we have a very impressive lineup of panelists tonight, and I'm excited to have them each introduce themselves to you. But first, we'll begin with a few words from David before we hand off the mic for introductions. So welcome, David. David Hochhauser, Hub Security CRO. Welcome to today's discussion.
Thank you, Sterny. I was just checking, by the way, the price of some of the cryptocurrencies for those who care. Bitcoin is down a little bit and Ethereum is up. But that aside, that's for the public announcement. Now back to why we're really here. I'm Dave Hochhauser, and as Sterny mentioned, I'm the Chief Revenue Officer for Hub Security. And it's essentially a company with really brilliant hardware and software engineers and expertise focused on protecting sensitive information, especially in healthcare. So welcome to what I think will be a fascinating discussion. I want to take 2 minutes really to just briefly explain why we're holding this session and what is the general focus, of the discussion. Now, there's no subject rules for any of the guests here, so we can veer into anything we find important, but this at least puts us in some perspective. And after I speak, we'll then keep most of the session focused on our guests. So first of all, why are we holding this session? One, you can see AI is really picking up speed. It's rapidly moving into advancing healthcare. You see it from everything from assisting in diagnosis, identifying treatments, monitoring complex and very sophisticated medical equipment. Just a couple of examples to put in perspective that I've come across recently. One, there's actually a pilot underway at University of Pennsylvania with AI, and it's actually assisting in reading medical imaging for brain tumors. Medical imaging, I think, is a perfect example for AI. And they're, in this case, using a very advanced technique called federated AI to actually expand the pool of information available for machine learning, making it more effective, in an area where we could discuss a little bit further. But it's been going on for a while. I mean, I've seen an AI system. Literally, it was demonstrated by a physician. This is one of the places where the engineers don't demonstrate, but the physician actually does. And it was using it to determine the best course of cancer treatment. And it reads in an enormous amount of information. For those familiar in that area, the amount of literature generated every day is phenomenal. And so what it does is it reads it in. It's able to constantly look at the latest trials and development and try to assist the physicians in coming up with the best course of treatment on. So there's fascinating stuff going on in this area. Now I'll tell you, in addition to AI, there's other really rapidly emerging technologies such as IoMT, or Internet of Medical Things, 5G, cloud, edge computing. Now, each of them by themselves has absolutely massive potential and are game-changing by themselves. Now, I find this all absolutely fascinating, but it also brings a host of really powerful data privacy and protection challenges and questions. So there was actually a 60-minute segment, I think it was a couple of months ago, and it's showing the benefits of doing AI on genomic data and the advantages of actually pulling in data from multiple sources and all the power that it can. The more data that comes in, the more advances you have. The interesting thing is the entire second half of the segment was how China is going about stealing all of our genetic data. So the two sides of the coin, hugely valuable. The other side is how do you go ahead and protect this whole area? And so it really surfaces a ton of questions about AI and the security technology, which essentially is what brings us here today for these topics. And I'll kind of categorize them into four major general topics. One is a discussion around kind of collaboration and data sharing, the value, the policies, the privacy and protection around that. The other one deals with kind of data integrity, the bias and protection of that. Another topic we'll explore is looking into AI and machine learning as cybersecurity tools themselves. And the last one dealing with security kind of edge and IoMT computing in healthcare as well. So we have a lot of interesting discussions. We do have each of the panelists talking, and then of course we'll answer all kinds of questions as well. So I hope you enjoy the discussion, and back to you, Sterny.
Great, thank you, David. And we're glad that you can join us today. So I'd just like to take a quick few minutes before we get into the discussion to do a quick introduction round. Starting with maybe Christopher, would you mind just giving our audience a bit of a background on yourself and what your field of expertise is?
Sure, I'm Chris Frenz. I'm the AVP of Information Security for Mount Sinai, South Nassau. I was formerly the head of security for Interfaith Medical Center, where I was the first person to take a hospital to zero trust. I'm probably best known for being an advocate for the cybersecurity role in patient safety, and I'm also the author of the OWASP Secure Medical Device Deployment Standard. I'm happy to be here today.
Great, thanks so much for joining us. And we're also joined by Carolyn Crandall.
Thank you, nice to be here. I'm Carolyn Crandall. I am the Chief Security Advocate at a company called Attivo Networks. I'm generally known for, again, being another cybersecurity advocate in the industry and really trying to help organizations as they look to evolve from current security practices to how do they build a more active defense or go on the offensive against cyber attackers, because they've gotten so sophisticated today. And I do spend a lot of time in the medical industry and working with both the different associations and the healthcare providers on trying to build the right architectures in order to be able to do that.
Great, thank you, Carolyn, and thank you for joining us today as well. And next we have Jack Lewin. Why don't you introduce yourself?
Sure. I'm Jack Lewin. I'm an internist and cardiologist. Most recently, I was CEO of the American College of Cardiology, and then up here, I'm in Manhattan today talking to you from New York. I ran the Cardiovascular Research Foundation. And, you know, as part of those roles and some of my work with currently my own consulting firm, Lewin and Associates, I've had a lot of exposure to cybersecurity related risks and solutions. I actually, full disclosure, I've worked with a company called Green Hill Software, which is probably one of the most advanced security companies in America. Fortunately, they protect our nuclear weaponry and a lot of aircraft. I've also worked with Hoyos International, again, another very advanced company in terms of cyber security protections. And I'm also an advisor to WebShield, which is an interoperability company and system. And I think some lessons from those will be helpful in our conversation today. So nice to be here.
Great, thank you, Jack. Glad you could join us. Cody Baumgartner.
Hi, Cody Baumgartner. I'm Division Chief at the University of Kentucky Medical Center for Pathology Informatics. So we primarily focus, or at least my role, primarily focus on the clinical application of genomics, digital pathology, and laboratory medicine. Prior to this, I've worked in a lot of areas of IT, including security and research, and then I also head up a innovation core through our Institute of Biomedical Informatics. Thanks.
Great, awesome. Thanks for taking the time. And last but not least, we have Ramzi Noali.
Thank you, Shirley. So good morning, good afternoon, good evening, everyone. My pleasure to be here today. My name is Ramzi Noali. I am a security specialist in Montfort Hospital. For those who don't know Hôpital Montfort, it's Montfort Hospital, it's an Ontarian Francophone academic hospital. So this hospital serves over 2 million and a half people in Eastern Ontario, Canada. So in both official language. What I do, so I have mainly 3 mandates for me. So I am dedicated to protect critical information assets against a variety of security threats. Second one, add value, and third one is helping people to achieve their goal. So thank you very much for this opportunity, and I am honored to be with you today. Thank you.
Great, thank you, Ramsey. That was a great introduction. So I wanted to start off our discussion. Well, we're going to cover a few topics, but I wanted to start off our discussion with the topic of collaboration and data sharing. So I think I wanted to ask you, Ramsey, just right off the bat, what are some of the data protection challenges that we face when it comes to using AI in healthcare?
Yeah, good question. I will take this question from two scope. The first scope is from change management scope and maturity landscape. So we know that the challenge for the healthcare, that is the professional, when they use technology, they need trust. They need trust this technology. They need trust AI, that it works, and this technology can support them and help him during their day-to-day activities. So the word trust, I think, resume the most significant barrier to adopt AI for healthcare settings. So, for example, like passion now, they didn't normally trust new software, because when I ask my patients, my visitor guests here in the hospital, what is AI? They didn't find a very simple, or they didn't find person they explain in simple term how it works. Also for doctors. So doctors, they ask me if they trust the application, coding application. It's this application AI is most calibrated with physician input, and it's based with accurate data. So from change and maturity landscape, and I can name it, its political side, the trust, it's the major barrier to adopt AI within a hospital. The second one is the legislative perspective. So when I remember GDPR, for example, the General Data Protection Regulation, it's built for transparency and accountability. So when we adopt AI, they use the profiling process, collect data, analyze, give response. It's machine logic of result. So it's clear from legislative perspective that AI, it's like black box for that. So the big challenge, if I resume, is the trust from doctors, from patients, and I hope also legislative be accommodate to this new technology and to facilitate to integrate AI with a transparency, with explainability, and fully trusted to our doctors and patients and healthcare organization. So I think we have faced two challenges, the trust one and the transparency one.
Thank you, Ramsey. Cody, I wanted to ask you, what do you think is the biggest barrier in applying AI to healthcare? I think you're muted.
I was just miming. No, I think a lot of it's getting at the data. We've done a pretty good job for several, maybe 3 decades at taking resulting data that's in EMRs, and we can look at that, and maybe we're getting some laboratory measurements and things. But a lot of this, even textual data, isn't discrete. It may be in the laboratory system, but by the time it gets to the medical record, it may not be. And even in academic medical centers, which have good ways of sharing data, you're not getting at where AI is currently really excelling, which is in imaging. In some cases, it's in natural language processing, but a lot of it is in imaging and in genomics, really high variable attribute data. And that's the Wild West, where you're seeing places make the news, some good, some bad, is in what's happening is agreements with departments, not institutions, are taking place. And maybe data sharing is occurring, but maybe it should, maybe it shouldn't. But getting a hold of that data, that institutions are sitting on a gold mine of information. And it's hard to get that information, say pathology slides or genomic information, and harness that in a way that the institution can use it, even if they want to. You know, these are in disparate systems, which are typically, I wouldn't say outside the scope of IT and security, but they're not things that people are paying attention to. You know, the actual underlying raw data assets. That's what I'd say is the problem: is getting, organizing, curating, and then matching up that data with the eventual results. Would be the biggest issue that I run into.
All right, thank you, Cody. I wanted to ask you, Christopher. Do you think the application of machine learning and artificial intelligence technologies will be limited to an individual organization, or is there value in sharing security information in order to make these systems even better for the entire healthcare ecosystem?
Sure, I'll answer the question generically first, and then particularly to security. On the more generic healthcare side, I think, as Cody just mentioned, there's a lot of challenges towards sharing and integrating data, even between systems within the same organization, let alone between organizations. But with that being said, I do think there is a lot of value in sharing data if we can work out a secure way to do it. I do think overall that sharing data is a good thing, and it will help promote better AI models. One of the things with any type of machine learning or artificial intelligence is the quality of the model that comes out of it is largely dependent upon the quality of the data set that goes in to train it. So improved sharing and other stuff will definitely result in improved models, as well as improved ability to validate those models. More particular on the security side, I do think sharing becomes increasingly essential between organizations. If you go to dark web forums or other things, one of the things you see is that the people who like to attack healthcare organizations, they share data back and forth. So the more we can do to share data and help protect each other, the better off we're going to be. Because one of the things we have to remember on the security side is that we're not really facing these threats alone. Any attack my hospital is seeing is likely being seen by other hospitals as well. So the more we can share what those attack vectors are, other information about the attacks, the better off we're all going to be.
Definitely. Jack, tell me, what do you think are the three most critical reasons why interoperability of critical health information, health data systems, and EHRs has been so slow?
Well, you know, I think the security issues get a lot of attention and focus. That, you know, we don't have enough security to share data in some ways. But I think the really more challenging and common reasons that we're not more well, as Mickey Tripathi, the new guy that runs the Office of National Coordinator, he, you know, conversation with him, and then back to the original ONC director, David Brailer, 20-something years ago. Why haven't we achieved interoperability? So it is, some of it is this security issue, but the incentives aren't really there for in many places to robustly share information. And the proprietary issues are major barriers, and they're not spoken of as much. But if you put all that together, you know, the trust and the transparency are important elements. But I think it gets down to, we still have a lot of proprietary barriers, and the incentives haven't been significant enough. And, you know, the federal government has been a little bit slow in using its leverage to say, if you're going to participate in Medicare and Medicaid and other big programs, you're going to share data. And that's where we're going to do this. We'll make it secure, and we'll do it together. But we're not quite there yet. We will be.
Hopefully. Question for you, David. Well, I know confidential computing is a means of safely sharing data. Maybe you can expand on this a bit and explain what confidential computing is and how it can help share and protect the privacy of healthcare data.
Yeah, sure. Yes, so diving a little bit more into a couple of things on what we could do from a protection, and I know there are multiple aspects to this. So one, just to explain confidential computing, because it is a term starting to come up very frequently on how to enable people to share more data safely. So think of it, there are three pillars of data security. One is you're protecting data at rest. It's sitting there encrypted, you're protecting it. The other one is you're protecting it while it's moving or in transit. The third one, which is really the toughest challenge, is how do you protect it while it's being used? So the first two are pretty standard. The last one, protecting it and the application itself, the AI algorithms themselves, is tough, because in essence, you need the data and the applications needed clear and open in order to compute very effectively and to do it. So what's happening is there are several approaches now in confidential computing network. It's essentially a new security approach that permits the actual data and the application and the AI to be protected even while it's running. So you can protect it while it's coming in, while it's going out. Now you can actually protect everything. And the only one that can see it is actually the code runs completely protected from anybody ever looking at it. The easiest way is to give you an example what it does. So one really interesting thing deals with collaborative machine learning. And so if you have 5 hospitals that want to actually share medical imaging information, the problem is the protection, the confidentiality and the privacy of that information. So confidential computing would allow you actually to have these 5 different hospitals share the information and run an algorithm, but none of the hospitals could actually ever see or access the other person's information. They can't even see or touch the algorithms. Even so no one, everybody could put it in. The algorithm can actually use all the data, but no one can see it. And not even the people running it can actually get at any of that information, even the people running it, yet they could all benefit from sharing that insight that comes out of it. And so it is one technical area that's really starting to pick up steam in order to be able to keep everything protected while at the same time being able to protect the privacy of everything that's going on.
I think that's a good segue into our next topic, which is edge and IoMT computing. And I wanted to ask Cody, where can edge computing technologies be used in the application of artificial intelligence in healthcare exactly?
I'm probably a good and bad person to ask, because that was the topic of my dissertation. So edge computing, and I'm also a faculty in computer science. So we do a lot of work in that inside of medicine and outside. You know, one of the pillars of the reason for edge computing is the idea that the law of the land, that you're able to manipulate the data either closer to sources of data generation or along the way, so that you can either detect or mitigate security. So a couple of those things is in the data curation process. And we do this within the lab all the time, whether it's dealing with genomic data in the clinical workflows and making sure that we have data integrity as we move it around, or in digital pathology, doing things like scrubbing the labels and identifiers from slides after they're generated to then send them off for, say, secondary QC or something like that. So being able to, and I have in presentations nice slides about the way we traditionally do things in hospitals, that we put things in a big bowl and then hope that nothing ever escapes outside. The problem with that being, if you're going to try to apply AI to these things, either building models or actually using it, it typically doesn't exist within the current hospital system. So edge is one way where you can both acquire data and apply policy and even apply models out towards the area where data is either being generated or where you want to collect or route it.
Great, thanks, Cody. Jack, you've spoken often in the past about your concerns regarding medical devices, and particularly implantable medical devices being hacked. So would you mind to just elaborate more on this and explain a bit more about where your concerns stem from and what do you think?
Yeah, in my role as CEO of the American College of Cardiology, and again in the Cardiovascular Research Foundation, it's amazing what we're able to do technologically, in terms of how much progress we've made, clinical progress. It's fantastic stuff. But in the cyber zone, we're really not where we need to be. So, I've gone to, some of you probably have had the experience that I've had where you go to a cybersecurity related meeting and there's a contest to see who can hack into all the most commonly used implantable medical devices in the United States. And before the end of the conference, everything's been hacked and people get little prizes and so forth. I've been in meetings in Europe and Scandinavia and Germany and other places where all the American devices, the common, the top brands are being hacked. And here's the thing, the guy who was the CEO of this company, Green Hill Software, who has done, I think, more spectacular things in terms of national security solutions, called me up one time in that role and said, what are we going to do about medical devices? Because medical devices like defibrillators, advanced pacing devices, insulin infusion pumps, and so forth, they're connected to the Internet of Things. So we can provide a kind of guided therapeutics. And this is really important in heart failure. We're doing more and more connection to the Internet of Medical Things to monitor people and to prevent crises. But the problem is these devices are easily hackable, and you could conceivably, since they're all, so many of the devices, they're all with the same kind of security protection, you could hack into all the people on a particular pacemaker or everybody on a particular infusion pump in the world, if through Wi-Fi or Bluetooth connections, if you hacked in. So I have been an advocate for getting the industry to move to improve this, and for some reason, the leaders of the device world don't really think it's that important that they're really targets. And there's a good reason why Vice President Cheney disconnected his defibrillator from the internet. It was a very, very smart thing for him to do. So anyway, I just want to point this out. This is true also with guidance devices in cars today, and it's for many other sectors of the economy. But we just have to do better in terms of some of the common things in healthcare. And I think that the solar winds problem that just occurred, and we're still just sort of demystifying that. But one of the simplest elements there in terms of that problem is, we really we shouldn't be using passwords today as a means of providing security access, because there are better biometric approaches that are much, much more secure than, say, a password system. And that's just kind of a simple step. But for devices and Internet of Things, hospitals know that many times the breaches that are commonplace in hospitals actually occur because somebody enters through one of the devices and gets into the systems that way. So that's an important area that's still unmet after 10 years of expressed concerns.
It definitely is a very vulnerable endpoint. It becomes very easily exploited. Carolyn, I wanted to ask you, thank you for that, Jack. Carolyn, so in a time where software and devices can no longer be inherently trusted, what security innovations should healthcare providers be investing in now?
Yeah, no, it's a great question. And a lot of the things that Jack was just talking about resonate a lot. And you look at, the SolarWinds example, Microsoft, SAP, Code Dev that just came out. There's so many things that are going on today that just show that networks are inherently insecure. And we're probably not doing enough to prevent the initial compromise, but we're definitely not doing enough to be able to detect that activity once it's inside the networks. And the fact that they can go undetected for so long is another huge red flag to us, because if we can't keep the intrusions out, we need to be able to detect them quickly and have better visibility, right? If one of these medical devices has a vulnerability, what are the attack paths to it? And if we can't change the inherent operations of the device itself, because if the manufacturers aren't going to do it, you can't really change it in the field because it may void the warranty or change the performance of the device. And so, some of the things that I do like is the FDA's new medical device development tools and the scoring model that they've put under that. I think that will help. So nobody wants to have a black eye as far as the scoring. You don't want to be the lowest on the list, and maybe that will be some motivation to get people to approve. I think there needs to be more biomarker testing to check and see how these things. I think we need to look at the, just all the things that can happen around this. And then let me go back to some of the fundamentals. So, inventorying assets, we know this has been an age-long issue. It's not getting simpler, it's getting more difficult, but we need to keep investing in the visibility, because if we understand the access and the attack paths, we can definitely help ourselves, even if we can't understand where all those devices are at any given time. And then, do the basic things: disable the vulnerable features, enforce the network policies, tighten your network segmentation up, and other changes in, in the device environment you may be able to modify. And then the last area I'll also talk about is two things. One around lateral movement and privilege escalation. It goes back to being able to detect that attacker activity inside of the network, and whether it's your main network, and a lot of devices are even connected, and managed through Active Directory. That's the treasure trove of information, and definitely not enough is being done in that area to make sure that an attacker can't come in and change the policies or change the operations or give themselves ownership inside of some of the group policies that are there. So I, again, encourage people to look not only at the devices, but the other elements that can have an impact on them.
Well said. Does anyone want to add anything to that?
Sure, I'll add a little in. I'm the author of the OWASP Secure Medical Device Deployment Standard, and one of the things I'm very big on is network segmentation. That's one of the ones that I can't stress enough. Limiting that medical device so only what needs to talk to it can and nothing else. That's one of the ways to go. Because if you look at hospitals and other ransomware attacks, one of the large contributing factors to those ransomware attacks is flat networks. Within a lot of hospitals, it's unfortunately not uncommon to have every device able to talk to every other device. And that creates a problem, because when something penetrates your perimeter, and something always will eventually, that means that one compromised PC now turns into a compromised network. And that's one of the things the hospitals really need to begin to lock down. The second issue I'd raise at medical devices is one of the big issues is one around availability. We have to remember that a lot of the medical devices that we run the same Windows or Linux operating systems that a lot of the PCs and other systems we have in our environment do. So if we have a threat that can attack a Windows desktop, it's also likely to impact a lot of medical devices within the organization too. And the reality is that ransomware does not just take out patient data, it can encrypt medical devices and other stuff as well. And that's where a lot of the real patient safety risks come in. You make a lot of those devices that are critical to care unavailable, and that's where the huge patient safety risk comes in. So, my advice would be to strongly for hospitals to begin to look at network segmentation. A lot of other technologies like DNS syncholling, things like that, can be great as well for medical devices. Because one of the other issues is you typically can't install endpoint security on a medical device like you can a desktop PC. But looking at the network traffic coming out of that device is a great way to identify if a device is infected or not. So begin to look at controls like that organizations can put in place.
Thanks, Chris. Is it okay if I call you Chris?
Yes.
Christopher. Yeah. Did anyone else want to? I think this is a really interesting topic. So if anyone else wants to jump in, feel free.
I would agree. I worked in networking for many years beforehand, and I don't know why a lot of people are hesitant to split up the networks like that. I think for 20 years ago, it made sense to try to pop everything behind individual firewalls. But even from a performance standpoint, it doesn't really make any sense to do that anymore. So along with the network infrastructure, the directory infrastructure as well. I mean, if you have your critical assets on the same directory that your individual users on, that is a risk that's unnecessary. And things are federated in a way now where it doesn't really cost you any more other than just in design and time to break these things up and really provide kind of layers of protection. So I think that's really the right thing to do.
David, so as we've discussed already, many edge computing locations are by definition not secure. And in addition, they don't have the benefit of being in a secure data center. So in your opinion, how can organizations protect their data and AI applications in such environments?
Okay. Great question. A little difficult for me to answer this without kind of plugging a little bit what a hub does, because some of that I think is extremely relevant. I think one point is a lot of these are dealing with local access, local systems that are coming in. It's what that edge device is actually connecting to in the first place. And essentially, I'll give you an idea of what we've done is essentially build a secure data center in a box. So that can be put on the edge. So if you have a system that's sitting in the hospital, it may not be in a secure data center, but how do you isolate that, and how do you protect that application that may be running and collecting information from 5 of these different devices and monitoring them, whatever, there's multiple kinds of applications they're doing. And I'll just, as an example, for at least what Hub is doing in this space, we've taken what's probably the most secure kinds of device. So these things called hardware security modules that are used by financial institutions and a lot of places to really secure the keys and in some cases a little bit more of what you're doing to access some of the devices. We've merged that, kind of reinvented it and built it out to actually put secure computing platform in there as well. So you'll have an extremely secure edge computing platform that has all of the crypto information, all of the security. We protect the network. We actually have a patented hardware and firmware firewall protecting every message going in, every message coming out of the device at the same time. And we also have very powerful CPUs and GPUs that can run the applications in the AI right there that might be controlling and monitoring the devices, for example. The other key piece, it's actually in a hardware, in a FIPS4 compliant box, so it's tamper resistant. So that's what we say, it's kind of like a data center in a box where literally if somebody, it's anything inside of here we consider not hackable. There's nothing that's 100%, but extreme protection, even if the person tries to pick up and walk away with it. So from our perspective, that's in effect at least how you have to seriously secure any of the edge computing that's going on, that's intercepting with these devices and control from there. I think it's going to be increasingly critical to have everything that intercepts to be an extremely secure computing environment that's working with it so that you can't break in from all these different angles as well.
Great. With that, I want to move on to our next topic, which is data. I want to discuss a bit about integrity, bias, and protection. And starting with you, Cody, what new technologies and techniques stand to change the landscape of artificial intelligence in medicine?
I think we're just now starting to deal with some of the integrity problems, and some of that has to do with the guidance that has been released by the FDA to say, okay, if you're going to build your own models or if you're going to go for approval, this is what it should look like. So in a lot of ways, we talk about data exchange as being de-identified, but in the same token, if you're actually going to build these things for clinical use, you actually would need to know where the data came from. So there's a bit of an issue there. So what I think that is very much needed, and I don't see much efforts in this area, would be to unify the raw data assets, to be able to interrogate the PAC systems and interrogate the digital pathology and all of these other non-textual things that go into EMRs, and then be able to keep track of that data from time of generation all the way through the point to where it's actually used by the model. Now, the other part of that question I would say is from a benefit from AI. Now, this isn't using an FDA approved model, but this into the data sharing is that even in imaging, you're going to have in pathology, you're going to have different stainings, you're going to have different devices. The data that somebody else may give me may actually make my model worse. So in that case, what you need to actually do is to keep track of the assets as far as the type of data. There's a new techniques that are being applied to medicine called generative networks. So general adversarial networks are being used to where I can say, take data from Ramsey's hospital and then take data from my hospital, and then I can apply the way that my staining looks, the way that my devices, the way my data looks to his data to then hopefully make better use of that internally. So I think keeping track of the assets from cradle to grave, keeping track of the actual the attributes of the data are things that we're going to have to start doing if we're going to be serious about actually applying this clinically.
Of course, and as you said, with any type of machine learning or AI, the training data that's used to create the model is of critical importance and is what needs to be protected. And Christopher, I wanted to ask you what protections, if any, are organizations using to ensure the integrity of the training data in their AI models, machine learning models?
Sure, I think this is a challenge for healthcare beyond just data used for training. Because as mentioned, a lot of the data is data that already resides in our EHR system, data that resides in our PACS system. So it's really a question about what are hospitals doing to actually secure the data they have. And for a lot of hospitals, that's actually a challenge. If we look at the 2017 Health and Human Services Cybersecurity Task Force report, they had several major security findings for what's commonly wrong in hospitals. One is most hospitals have a lack of security talent. In most hospitals, there's not even a full-time security person that actually works for the organization. Obviously, for a lot of bigger hospitals, that's not the case, and they have security teams. But if you take an average of hospitals, there is a lack of security talent within most hospitals. You combine that with an environment that has a lot of legacy devices. A lot of legacy devices which can't be patched anymore, have a ton of vulnerabilities, and makes those devices easy to compromise, which further kind of compounds the challenge. You add to that the fact that in a lot of cases, there's been a lot of premature overconnectivity. As the push for meaningful use and other guidelines, it pushed a lot of systems and devices online quickly. And when you do that with a lot of legacy devices without really giving much thought to how they're going to be secured, it creates a problem. And I think you've seen a lot of that problem in a lot of the ransomware attacks that healthcare has seen over recent years. I think another common issue you see in a lot of healthcare organizations is they're heavily focused on things like Hipaa compliance, but there's often a big difference between compliance and security. In a lot of cases, you can check the box and be compliant, but still be pretty insecure. I think we see that in a lot of cases as well in hospitals. I kind of view compliance like trying for a D grade in the classroom. Yeah, you may check all the boxes to pass, but doesn't necessarily mean you're doing a good job. And I think too many hospitals are concerned with just compliance and not actual security. So I think those are all big issues that hospitals need to address. And I think last year has actually been particularly challenging because with the onset of COVID, you had a lot of hospitals now forced to roll out telehealth, roll out remote access, all kinds of other technologies. And oftentimes they were rushed out and many hospitals didn't give a thought to security. So it's created a real challenging environment for hospitals in recent years to keep up with security. I do think that is starting to change. I think hospitals are becoming more and more security conscious. You are starting to see upticks in investment within cybersecurity, within healthcare, but most organizations do unfortunately still have a long way to go.
Definitely, and I think 2020 saw the biggest spike that we've seen in ransomware attacks on healthcare organizations, and I think it's been a wake-up call for many. My next question, I wanted to throw it back to you, Cody, for a minute. For generative models that can create synthetic data from real data, does the model or the resulting synthetic data need to be protected as well?
It probably depends on what it is. If it's somebody's face, maybe. If it's some de-identified cancer model, probably not. I mean, what you're looking for in like an encoder models can take and do transformations on existing real data. What you're hoping for in generative models is to actually create synthetic data. So somebody may argue with me, but I think in general, what you're looking for in advanced synthetic models is that you can actually take you're taking what looks like real information, or like the picture of Tom Cruise, and then applying it to somebody else. And I think in this case, this is a really good area to where the federation between areas to get those high numbers, the 10,000 and 40,000, to get in the high 9.99% on classifications, you need lots and lots of data. If we're able to create general models, which then can be transformed into something that would be more like my staining or my location that I could actually use to do testing on my side, then I think that would be useful. But I mean, my opinion though, is if you're generating synthetic data for certain types of information, that I wouldn't think that I would have to necessarily be protected, but maybe it does.
Carolyn, many organizations are now shifting to an identity-first security posture in order to protect sensitive information. I was wondering, how do you think this will affect healthcare providers?
Yeah, no, it's an interesting dynamic, and a lot of it was, pushed forward with the remote workers, and instead of having everybody behind, their typical protection barriers, that people had to think differently, right? At all these different devices, all these different home networks, all of these different things that there was less control over. So what it's done is it's driven a different conversations among the security professionals and the CISOs, that instead of thinking of things at the LAN edge, think about identities. And when I say identities, it is the people's credentials, it's their privileges, it's their access to information. And if you try to do it, although I do firmly believe in network segmentation, but if you try to do this around providing not only the right authorization and authentication, but also putting up the right types of conditional access so that if that person not only doesn't have the right credential, the right privileges, using the right tools, that maybe they can't see that database of information or document, or maybe they can't get access to that application. And so, there's a bunch of technology that's been out. It's still developing. It's probably been a little over complex for most healthcare organizations to adopt unless they're big and have the right security teams. But I think there's a lot of technology that's coming forward right now that you can now start to think about it as identity protection for anyone, anywhere, anytime. And now also how you cross it from those endpoints into the directory services and environment, and also into the cloud as people move and adopt there today. So I think it's something that should be a priority for organizations, and kind of that crawl, walk, run is, how are my credentials, right? And do those credentials, or what's happening on the endpoint, let me get into those directory services and change things? And how do I at least shut those things down? And then look at ways to get more sophisticated upon, entitlement and conditional access. And as people would also maybe correlate this to a bit of the zero trust model and what can be done there. Zero trust or least privilege are definitely things that should be on every CISO's mind. And it's a process, right? It's kind of like the journey versus the destination. I don't just say one day I'm going to have zero trust. It's how do you build a program that gets you as close to that as you can, given your operating environment. And I firmly believe you've got to be thinking about it from an identity first posture to really make that achievable.
Definitely. And you touched on zero trust, which is something that I hope that we can discuss a bit more further on. But I wanted to ask Jack, because this has come up already, and I can hear the frustration in your voice when you talk about it. HIPAA, so regulatory compliance, is it really as big of a barrier to protecting health data and AI as it's typically presented to be?
Yeah, HIPAA gets a lot of play, and people, there are huge concerns about it and so forth, and it's become more of a barrier than it needs to be. I think we do have to protect privacy, and the laws are written for good reasons, but we don't need HIPAA as a huge barrier to being able to share data and to move forward with AI and so forth. I've been working with, interestingly enough, I mentioned earlier a company called Hoyos Integrity, who partnered up with Green Hill Software, the folks out in Santa Barbara that have been probably the most sophisticated defense cybersecurity people, to build a phone, which is now on the market, but it's a phone that is, and I'm saying this securely, it's unhackable. It could be hacked if your body and brain were part of the hack process, but otherwise the phone it's going to be insured for millions of dollars to protect, to guarantee that they're serious. They've done a global contest with a $10 million prize to see if the phone can be hacked, and it hasn't been hacked. The phone is going to be on the market mainly for people like the State Department and the Secret Service and the DoD and those kinds of users at the moment. A 5G version of it, though, will become available this fall. It's not really a cost barrier to have this kind of level of security built into the phone. And really the two reasons of why it's so secure is because all the parts were thoroughly, completely vetted by Green Hills before they were assembled. Then the phone assembly done by Motorola is completely secure, like a secure laboratory. And all of the software, 100% of the software, has been evaluated and mostly rewritten by the parties involved to get to this place. But the beauty of it is that for healthcare providers and for hospitals, you could use this phone and literally call anybody and discuss any kind of confidential information with the absolute assurance that it will not be hacked. And that's going to be for voice, for text, for email, and for data exchange in these devices. So look for the Hoyos Integrity phone on the market sometime soon. I have no invested interest in it, but I've just been an advisor to the process. But here's an example of how we could sort of get around HIPAA. Now that the patient isn't going to not necessarily have this kind of security. So at their end, the patient could be releasing sensitive data, but by definition, when the patient releases data that's theirs, it's not a HIPAA violation. So there's some progress in this regard. But I think the other side of it is that we need to be careful that we're not using HIPAA as a barrier to clinical progress we need to make that will really benefit patients. So, it is a frustration. The law is there for a reason, but I think there's going to be progress around sharing data securely without HIPAA violations in the near future.
Right, thanks, Jack. Christopher, as computer-aided diagnosis systems and other forms of artificial intelligence and machine learning become more mainstream in healthcare, what are some of the new concerns that these kinds of systems introduce, the new kind of security and cybersecurity concerns, that these systems introduce? We already covered a bit of it, but if you want to expand.
Sure, I think there will definitely be some new security challenges introduced by that. For example, poisoning of a data set used to train. If you poison the training data, you might get an incorrect outcome with the model. So there are a variety of new issues that will come about. They can often be addressed by a lot of the standard things we do today to protect data sets, but it does introduce some interesting new risks. Some other things I could think of in that regard is, for example, on the security side, there was the antivirus Cylance a few years back, which uses machine learning to detect malware threats. And by making malicious code that represented common executables, people were able to sneak that by the machine learning model. So I do see the potential for a lot of attacks that kind of mirror that too, where you try to make something look similar to something else in order to get it to bypass the system. I think there's probably going to be whole classes of flaws that deal with exploiting the logic behind a lot of the machine learning. So I do expect to see new types of attacks come up as a result of a lot of the AI as it becomes more and more prevalent. I don't think it's something that we've seen yet in healthcare to my knowledge, but I do think it does create some additional attack vectors going forward, and it will be interesting to see what additional classes of attacks come out of the growing prevalence of these models.
Cody, you look like you want to jump in on that. You're stroking your beard very
I was still thinking about what Jack was saying about HIPAA, because it's a trigger for me. And I was in medical research in around the 2000s, and at that time, IT and healthcare, and that was the first passive HIPAA. And at that point, IT organizations were there for, and hospitals were there for service. And when I came back in 2017, they were there for compliance and data, and it was no longer that way. And I think people forget about the other part of HIPAA is the portability. It's supposed to make it to where we can actually access the data and not as a barrier. So as we're applying AI, I think you're going to have to shift gears. IT organizations, security organizations are going to have to think about not how do I protect the data as far as keeping it all hidden. It's how do we go about actually making sure the right people have access to what they need, not just within their little group, but broader. And it goes back to what David was saying as far as any of the protected computing. A lot of people probably, I would say most hospitals, if you said we have a perfect model for XYZ and we're going to give it to you, they would have a really hard time making use of it. Injecting AI into clinical workflows, even if you already have the trained model, is not an easy thing because hospital systems aren't set up to do it. So if you have an academic medical center where you both have a reason to do this information and you have the data, the hospitals typically don't fund the exploratory work to do the model training, okay? The research side is not going to fund something for the hospital. So you have this gap where you can't use public clusters, you can't use national labs to do the type of modeling that you need to do. And now the models are getting so huge, it's not like you can do it under your desk. And then even running inference, if they gave you the model, would be something that would be difficult. So there's a real problem in bridging that gap between what hospitals typically do and how they protect data and actually using AI, even if we had it available to us. So that was mostly my frustration with HIPAA and how things are kind of, I think we're taking a kind of brutish approach to dealing with security by just saying, well, no, you don't have access to it anymore. And at least that's been my experience, fast forwarding 15 years from, yes, we'll give you whatever you want, which was probably more lenient, to no, you explain to me why within your own department, you want certain data sets. Hopefully the protected computing would help that.
And the stuff I've seen though is, well, Cody, at least a few, and you may have seen more, is some of the ones are actually, you're right, they're complex. There's a large vendor, I've seen it either with Intel running it or IBM and the university and 5 hospitals. So there's a major player coordinating it, and they become big complex effort. It's not a matter of, hey, let me just drop it in. And hopefully that kind of research can get done more. And maybe it's just a matter of dropping in the inference engines, then the machine learning will be a little bit easier to do. I think it's going to be hard for the individual hospitals, but so far the ones I've seen are major collaborative efforts.
And that's typically to generate the data set and to publish the paper. Find places that are making active use in it in the clinical pipeline, and it'll be much less. So that's the gap that needs to be bridged. Of course, there's security and data quality issues that will prevent some of that from happening quickly. But that's the thing that we're focused on, is how would we go about making AI look like a laboratory-derived test, something that we could validate internally. We don't have to wait for an FDA-approved model. That's something that we could do, but that's a harder thing than one would think.
Great, thanks, Cody. And with that, we'll segue to our last topic, which is artificial intelligence and machine learning, and ways that it can be used to bolster cybersecurity. And I want to start with you, Carolyn. We've seen ransomware attacks on healthcare providers take a sharp rise in 2020, and in 2021, the trend continues. How are security teams leveraging AI to combat these attacks? Are there ways that we can learn from that are already being used to protect these our vulnerable healthcare systems?
Yeah, no, it's a great question, and a lot of companies do use AI inside of their technology, and there's a lot of focus on it. But it's an imperfect model, because a lot of times what you're doing is you're looking at logs and information to try to look up signatures or pattern match things, or look for other heuristic information that will tell you that something bad is happening. But a lot of times what happens is, by the time you get all that information together and correlate it, it's the car has already crashed into the wall, right? And then it takes a lot of time to do the intelligence. And so I do think there's a lot of benefit in using AI to try to be predictive. And I do think it's useful if we can apply it to faster correlation, or some people may call that the machine learning piece of it, to faster correlate the data, get the threat intelligence. And I guess one piece I would put on that, if anybody is following the latest Mandiant report, you look at the dwell time, the time it takes to detect an attacker, was cut in half. Right. And you may go, hooray, security teams have gotten better. Or you may go, oh my gosh, my time now to detect these has gotten really short. So now my time to respond has to get even faster, right? You got to find them faster, you got to respond faster. And so I do think it should be a focus of every organization to take a look at how they incorporate it, but it's also a barrier for a lot of these smaller organizations, because they don't have the teams, the resources, the skill set to be able to go through all of this information, weed out the false positives, and get to the data that they need. And again, time is of the essence now. And so, I think, and I know I kind of harp a little bit about on the identity and looking at conditional access to things, but I do think if you think about attackers who are using AI themselves, right? So instead of trying to find every signature and behavioral piece of it, to say, okay, what are the techniques, and go on the offensive to say, if you even look at ransomware and the commonality of the playbooks, there are certain things, and you can use the MITRE ATT&CK framework, which does an excellent job of outlining that, or a kill chain model, to see what are the things that all these different types of ransomware are doing, and say, if you can do a technique-based detection to say, let me anticipate what they're going to do to steal credentials, to look for ports and services to exploit, look for the other activities, you're going to get more accurate detections than necessarily trying to call through everything that AI might think is an activity. And so I guess my suggestion is AI should be a part of it, but also use things like vulnerability assessment information, get ahead of it, look at the attack paths that are going to come off of an endpoint, and make sure that you've got the right detection measures in place that are more based upon technique versus having to rely on AI as a detection method, which is good, but still generates a lot of false positives the way that it's being used today, and misses things.
Correct. That's correct. Definitely. Thank you, Carolyn. And Ramsey, I wanted to ask you as well, how do you see healthcare organizations using AI to bolster their cybersecurity?
Yes, thank you. It's a good question. I continue to proceed what Carolyn has said. Effectively, we are now, and from 2020 and now 2021, the cybersecurity is a war. So we are in the war against ransomware, malware, and a lot of huge number of attack to healthcare organizations. So we know that from 2-3 years now, the growth of number of attacks, threats, kind of severity and complexity also. So I think that the artificial intelligence can help healthcare organization to detect vulnerabilities and respond to data breach faster and with great precision. From my experience, I know that healthcare organization and also mostly organization, and I have a number that 63% of organization, they didn't have enough staff to monitor threats 24/7. So, and also, and the data, healthcare data, it's more valuable than standard information like social security or credit card number. So I think AI can boost and simplify security. So I select two major factors where AI can help us. The first one is to protect healthcare data. So we know now, since last years, that vendors and in the market, we find a solution, AI solution within network equipment like Cisco systems and IBM Watson solution. So I think it's this kind of change in the market. We find AI solution within network and IT solution is help us to enable hospital to protect against zero-day threats. So we can target fastly all undiscoverable weakness. So the first one is AI can help us to protect healthcare data. The second one is, I think that AI has a very good progress to predict unusable behavior. So I think this technology is it's more development with AI solution, so can help hospital to reinforce existing security structure and protocol. In other hand, unfortunately, I want to add that AI, the bad guys and hackers know now the strong of AI. So cyber criminal now is organized the growth of this defense done by AI mechanism. So they also use AI to counter organization AI defense. So now we have another war to win against AI used by cyber criminal. Just my last advice for that, I advise organization when they plan to put AI enable security, they didn't left autopilot when they deploy AI. They need absolutely make their change management carefully before deploy and after the implementation of AI, and make a risk evaluation and continuous to be sure that we can use AI in the good way, in the good fields, so AI can resolve all or specific problem facing a hospital or clinic.
Definitely, thank you. Since we are coming up on our last half hour, I wanted to moved into Q&A. So we have about 20 minutes, and I will just throw a question out. Anybody can feel free to jump in and to answer. Feel free to just to feel more open to talk with one another. So I'll just throw out the first one that we have here from our audience, which is, what are the maturity levels of the healthcare industry in following, preparing, and implementing AI and protection of data?
I would say
one of the features
infant.
is to imagine. I mean, the real risk in the beginning, of course, is with machine learning is where are the sources of data coming from? Can you trust them? So it's back to trust and transparency, and to a certain extent, as we're bringing sources of data in to advance AI in the actual development of it. But I think on the other side of this, we've just had this great discussion about how AI can be both a deterrent against cyber risk and a contributor. So it's a very complex matter.
I think just add what Jack was saying, and previously with AI, I hope billions are invested in AI related security, not because I necessarily want to be bothered with AI and security, people saying, what are you doing? But the tools that are used are essentially the same. There's a finite number of media sources, and the models are generally similar. So if you can pull in time series data related to the network traffic or credential usage or any kind of access usage, that's very similar to what you would look at for potentially biomedical data looking at individual patients. So I think similar to how AWS was started as an afterthought and now is the biggest revenue generating area, if you have hospitals that were focusing on the general application of AI, whether it be through security or for patient models, then that would probably be a good strategy.
All right, so next up we have another question from our audience, which is, what are the basics, the basic ethics, risks, and compliance needs to consider in protection of data for AI? I think we covered some of this already, I know, but
the ethics. I'll add a couple of things. I know there's a lot of stuff ethically. Some of the things, just as an example that I've seen, is one, you need to actually give permission, right? So there are ethics. So I was talking to one of the companies that collects genomic data. They're more commercial to give information. Now they have a huge pool of genetic information, but not available for any kind of medical research, because then they would have to start getting involved in going back to every single one of their customers to get permission. And then if any of them ever said, hey, I don't want to be part of that, they have to go back and find everybody they gave it to and pull back. And it's too much of a liability. Then there's an issue, well, if so do you make everybody do it, or do you start financially incenting people? And then you have some issues about, well, you can only get pools of data from people who really want the money or need the money. So there's a lot of challenges. There is a group, an Alliance for AI and Healthcare Research, that has a working group actually now. They're actually starting to look at some of the policies and technology behind it, and actually going to start lobbying for some regulatory changes as well, because there are a lot of complexities, and sometimes I think we always swing too far when we pass a regulation, and then we have to look at what are the things that are really good for everybody when you're doing research, and what are the things you're doing to protect. So it will be interesting. There's stuff in Europe as well. They're looking at a new regulation to be able to protect the use of AI. The other extremes, if you look at the social scoring thing that's going on in China, where everything is open for the government to take about you, whether it's medical, any kind of information, to create a score that's going to be used for everything about your life. So I think it's one of those cases too, where there's a lot of ethical issues and the policies often fall behind the race of the technology where it's going. And I think there's a lot of work, so there's a ton of ethical issues. I mean, it's a long question, but there are a lot of other interesting things to think about along there.
Definitely. I mean, you said China, everyone's face dropped. So I think we all understand the implications of and the importance of data privacy.
Well, they don't have the data sharing issue.
There's another thing in the laboratory we deal with, especially in genomics, and that's what do you do when you discover something and the person's right to not know? If you can't do anything about it, if there's no treatment, or if it may not happen, is that when we look at certain panels, that we exclude that information from the providers because it's not part of the panel because of those reasons. So when you have certain people applying AI maybe to full genomes, should the person know? Is there a right not to know some of these things?
Interesting question.
Or do we have to have a kind of an ethics around disclosure? Much as when it was back in the day when people with HIV was a death sentence, had to be told with a one-on-one therapeutic process rather than just getting the information you're HIV positive. I think we look at genomics and genetics in a similar way. We've got to develop a whole ethical construct around how we divulge that information to whom and when it's cruel.
Thanks, Doc. We have another audience member who asked if we can talk a bit more about zero trust architecture. We only have a few minutes, maybe for this particular question, and it's quite a large topic. But if anyone maybe wanted to share something more specifically about zero trust when it comes to AI.
Sure, it won't be particular to AI, but I can definitely talk about zero trust. Back at the previous hospital I worked at, we started our zero trust initiative in 2015. And I think one of the interesting things actually beyond the zero trust itself is why we made the decision to go zero trust. What we decided to do was actually simulate a ransomware attack. So we used what's called the ICAR test string, which for anybody unfamiliar with it, it's a harmless string of characters that many years ago, all the AV makers got together and agreed to treat as a virus. So it kind of provides an interesting way to test endpoint security. So we wrote a script that took a listing of all the PCs in the organization and attempted to basically copy this ICAR test string to the various PCs in the organization to kind of simulate malware spreading through the organization. And we learned a lot of stuff by doing this, both in terms of what technical controls worked, what didn't work, as well as how people were going to respond, to the incident. So, but to kind of keep it to zero trust, one of the things was we learned that the network segmentation we had in place was very effective at keeping the threat contained to just the department the script was launched in, because it was segmentation by department at the time. The interesting thing we learned, though, is that clinically speaking, if we were to lose our let's say, entire radiology department or an entire clinical department, it was still going to be disastrous for hospital operations. So we started to think about what we could do to take network segmentation to the next level. And we approached it in a couple of ways. We started with the data center, where we used VMware's NSX to kind of microsegment all the servers in the data center. And for the physical network, we approached it more through a NAC appliance, where we put policies in the NAC appliance to allow PCs to talk to the server subnet, but nothing else within the organization. So no two PCs in the organization could actually communicate with each other. They could only communicate with our server subnet, and that server subnet was microsegmented with NSX in order to ensure that that particular PC could only see the servers it needed to and nothing else. And kind of at a really high level, that's kind of the approach we took towards approaching that zero trust mindset. With that being said, zero trust is more of a journey. There's always going to be things you could do to further lock things down, further improve. So advice I would have to people who wanting to do zero trust is to first really figure out what's on your network. Do an asset inventory. Take the time to make that as complete as possible. Then once you have the asset inventory, begin to actually map out how those various assets actually talk to each other. And that's going to be the biggest challenge you find. The more completely you take out the time to map out how the various assets on your network talk to each other, the better you're going to be able to create policies, and the less likely you are going to be to break something when you begin to put rules in place. And once you put rules in place, start simple. Do the really low-hanging fruit first. Segment like things like DNS or DHCP servers, things where the network team really understands the ports and protocols, because your chance of breaking something is going to be much less because they know those services inside and out. It gives them a chance to learn the new tools that you're introducing and kind of progress from there. So take it slowly. It's going to be a long journey. It's not going to be something you're going to do overnight. It took us about 18 months to 2 years in that range to kind of get it to something that resembled a more fully zero trust network. But it's a process, and take your time, begin to do it by developing an asset inventory and figuring out how things talk to each other.
Yeah,
if I could
I need to. Sorry.
Sorry. Go ahead. Go ahead, Ramsey. Okay, so I was just going to add on to what Chris was saying. I think, that network visibility, and the piece I would add on to it again is it's not just all about the devices, but it is about the credentials and the privileges. And so a quick win for many people, again, if you look at these big ransomware attacks, is if they could change those policies potentially and reset their access or give them the ability to turn on and turn off things to their advantage. That I would again stress that as part of that architecture that Chris talked about is don't forget your Active Directory environment, and that you get the right visibility. And there's a lot of tools that are out there today that make, not only the network visibility easier, but also that attack path visibility and those vulnerabilities to Active Directory more visible. And I would say there, without getting overly technical on it, it's there are things like golden ticket or silver ticket attacks that you might go, well, I either resonate and understand what that is, or I don't understand what that is. And if you don't understand it, and you're not looking at how you protect against those type of things, you are going to be at risk. So I just want to make sure that, if you can protect everything around it, but somebody can go in the middle and change it all without you even knowing, then that is a very high vulnerability and risk that you want to be thinking about. So just kind of adding on, I think Chris is right in the things he introduced, but I would just say these are important and can be very quick wins without maybe some of the complexity that Chris had talked about. So sorry, over to you, Ramsey.
Thank you, Caroline. Exactly. So I continue with the quick wins. Definitively, I continue with the Christopher and Caroline speaking. So from zero trust side. So the approach is, I speak for the healthcare organization and others, is to make sure that we proceed with deep securities. So we need to diversify and to put multiple layer inside, outside our perimeter, to make sure that attackers and cyber criminals, they have a lot of many layers to attack. So I take example in NAC, network access control. So hospitals and clinics, they can deploy a NAC solution. Now this technology, it's available with the new generation firewall routers and core switching. So they can do this quick win. Another point also very, very important is the awareness and training of people. Is within the zero trust also. We didn't need trust everyone, everything, and every protocol. So, and the human, unfortunately, it's the least component in our security posture. So awareness and training, it's a must to have to deploy within with centralized and enterprise solution within our hospital and clinics to prevent phishing attack, to prevent social engineering attack, and so forth. So I recommend fortly that healthcare organization deploy and plan automatic simulation phishing at large in their organization.
Definitely. Thank you, Ramsey. And I think we're going to wrap up soon. I'm just going to ask a final question that we have here from someone in our audience. Is there a certification available that you would recommend for individuals that are looking to learn how to be ready to protect healthcare organizations specifically? Okay.
I think it depends on which aspect of security. There's lots of different security certifications. It's going to depend on the level of experience of the person, what particular type of security you're looking to target. If somebody wants to be a web application pen tester, I'd recommend, different skills than somebody who wants to work more on the compliance side of security. So I think it's really going to, depend on what particular interest the person has in security.
All right. And with that, I want to thank everyone for joining us today. And thank you to our speakers, David Hochhauser, Christopher Frenz, Carolyn Crandall, Jack Lewin, Cody Baumgartner, and Ramsey Noali. We hope that you're all staying safe and healthy, and we look forward to hosting many more discussions like these in the future. To get in touch with any of today's panelists, feel free to reach out to them directly. All of today's attendees will be receiving an email within the coming days with the contact information for each of our panelists. So don't be afraid to drop them a line if you have further questions on any of today's topics that we discussed. And to stay up to date on upcoming webinars, you can follow Hub Security on LinkedIn and on Twitter. And you can also check out our weekly digest on Medium. And look forward to speaking with you guys again, hopefully soon.